Okay, so cancer can affect all parts of the body. Let me start with the incidence and why we need to know the statistics. Okay. In this page. And I'll go back to that. Oh, we don't have it. Anyway, let's go to the cancer.org website. Sorry, it should be 2022. So who is the American Cancer Society? Can you see the cancer.org website?
Yes.
Okay. All right, so this is the government website. So they are funded partially by government and also private funds. So they compile statistics, do research, fund research, private research is included. So again, funded by the government and also with private donations. You can donate yourself if you want to. So they support drives, breast cancer month. So they have all sorts of support to find a cure. Again, most of their work is compiling data, and these data are both from public and private sources. Now, the statistics is important because they need to allocate funds. We obviously have limited money, so we need to fund and use the money to where it's needed most. I can't find the statistics right now, but let me try searching. Okay, here it is. So this is the statistics I was looking for. So if you look at above the line and then below, so the top is new cases. So these are not the same people, all right? So the statistics above this line is for new cases, meaning new cases reported, and below are the deaths. Again, these are not the same people. So this could be new cases, and these are cases of reported cancer death, and that means these are still living because this is all 2023. So these people here, these numbers died from these types of cancers, and these are the people still living with cancer, and these are the top cases, male and female. Now, if you look at the figure, which are the top three for males?
Prostate, lungs, and colon.
Okay. What about for female?
Breast, lung, and colon.
Okay, so they have similarities, right? So lung and bronchial cancer, along with colorectal cancer, are number 2 and number 3 for each gender. So this didn't matter, right? Whether you're female or male, number 2 and number 3 killers are bronchial, lung, and colorectal cancer. Whereas for number 1, prostate is the number 1 case for males and number 1 case is for females. But if you look under mortality, what is the number 1 killer for each gender?
Lung and bronchus.
For both, right? For both genders, it's the lung and bronchial cancer, then followed by prostate and breast respectively, and then last colorectal cancer. So what's the implication? And if you were the decision maker, let's say you were advancing in your degree now you reached upper echelons of American Cancer Society, or let's say you're a top decision maker in a insurance company, a health insurance company or a hospital, where would you put how would you use these statistics, and where would you put your money?
Lungs.
Why?
Not only it's the highest in terms of mortality, but I would say it's because of the airway.
Well, you're not living under a rock, right? You're aware of what's happening in society. What prevention advertisements and drives do you see?
To quit smoking.
Okay, yeah.
All right, we have quit smoking. But if you look at it with all this encouragement ads, okay, different speakers advocating, we have laws already. We passed laws banning. Have you seen cigarette commercials? Cigarette, okay, not vaping. Cigarettes commercials. Have you ever seen cigarette commercials in your lifetime?
Yes.
No.
Have you?
Yes.
No.
When? Because you're a different generation. In my generation, yes, I saw
Like in the 90s,
cigarette commercials.
Well, the really gruesome commercials where like they have to use that machine when they have the hole in the throat.
No. That's already a ad for quitting smoking.
Not to
That's
smoking,
different.
yeah.
Oh, the Marlboro Man,
A commercial
Camel guy.
selling, commercial selling
I'm sorry.
cigarette.
Marlboro Man, the camel guy, yeah, all of those guys.
Not anymore. No, there's
not
no
anymore.
No, not anymore. No, not
Yeah,
anymore.
because they were banned. Okay, the laws were passed. Okay, so that's one thing we've done, but yet look at the statistics. Okay, so it's still number 2 on incidence and then number 1 for mortality, because there's really nothing we can do as far as screening, because there's only one screening, which is a CAT scan, and and that's secondary prevention. Primary, of course, is to quit smoking. We don't have laws against vaping yet, because in order to pass laws, you have to back up data. That's how it is in America. Probably in China or some other communist country, they can pass laws with impunity, but not here. Okay, we are a democracy, so we have different processes here. So we have to, we can't just drive a business down because we want to, right? So there's due process. So smoking was proven to be number 1 cause of cancer, so that's why they were able to pass the laws, and it passed muster. So it passed, of course, the tobacco companies appealed. They filed lawsuits to have the law invalidated, but then they were upheld by the Supreme Court. So that's why we have those laws. But look at the statistics. Okay, so that means, where would you put your money? Are we doing enough to prevent lung and bronchial cancer?
No.
No, obviously not. Okay, so these numbers are important. So we need to gather data. That's why the government funds, cancer research, through cancer.org, because we need this data. Where do we put our money? What are we doing wrong? So why is there still these types of cancers? Why are they so high mortality? Okay, so this is the importance, one of the important works of American Cancer Society. All right. So this is just to give you a perspective, of how these government institutions work. All right. So let's go back to the chapter. Let's go now to the next page under pathophysiology. Okay, characteristics of cancers, and then we'll discuss how they develop shortly. Some of you are in the room, you may need to either lower your volume or mute so there's no background. All right, so we'll discuss a few terms here, but before we do that, let's compare normal from, this table doesn't really include the normal, so this table is just comparing benign and malignant, but I'll add the normal here in terms of benign, because benign tumor cells kind of resembles normal cells, except for a few factors, especially the mode of growth. So let's start with this cell. Okay, when we say well-differentiated cells, that means we can identify the cell. Okay, so the cell is distinct. It has a distinct shape. We know exactly what cell it is. So as far as benign cancer cells, they resemble normal cells. So you can't really differentiate them based on their appearance. Okay, so you can identify, oh, that's a breast tissue, that's a breast cell, oh, that's a bone cell, that's a brain cell. Okay, so when you get a biopsy of that benign tumor, they look normal under the microscope. Malignant cells, however, are undifferentiated, meaning they do not have a distinct shape. Very little resemblance, if any, to the normal cells where they are found. So it's easy to identify. And as far as the immune system, because our immune system fights cancer, so they can identify malignant cells. So in terms of immunotherapy, which is a big part of cancer treatment, very expensive, they use the immune system. They arm our own immune system in order to better fight cancer. So it's a challenge in terms of benign cells, because malignant cells, yes, they can identify. Our immune system can easily identify malignant cells because they look different. However, when it comes to benign tumors, immunotherapy is not very effective, because why? They cannot distinguish between normal and benign cells because they look the same. Does that make sense?
Yeah.
Next difference, mode of growth. So we can identify benign because although they look like normal cells, however, they grow too fast. They have a higher mitotic index or mitotic rate compared to normal cells. They grow rapidly. However, although they grow by expansion, they do not infiltrate surrounding tissues. Although they can box out normal tissues or organs, robbing them of blood supply and nutrients, these cells cannot infiltrate, meaning they cannot metastasize, they cannot spread, they cannot go beyond the body system where they are found. Okay, so that's one thing I wouldn't say really good, because let's say this tumor, since it grows by expansion, it really depends on where this benign tumor is, if you're talking about mortality. So maybe if a benign tumor is growing in your abdomen versus if a benign tumor is growing in your skull, which one is more deadly?
The skull?
Okay, because the skull is a limited space, right? So we don't have much space inside the skull. If you put a rapidly growing tumor in there, that can kill the patient because it will destroy brain tissue. However, if it's growing in the abdomen, do I have more space in the abdomen?
Yes.
Yes, the abdominal wall can expand. Okay, look no further. Just look at me. I have plenty of space, so I can grow one or two tumors in there, and I'll still be fine, I guess. Whereas in malignant tumors, they not only grow rapidly, but they have no contact inhibition. So because of that, they invade and spread to surrounding tissue. So they can use the lymphatic system, the vascular systems, okay, to spread, to go beyond where they are growing. So they can spread to different organs. Contact inhibition is what this means is normal cells usually stop growing when they hit a wall. Example is your wound. So who's had a cut recently? A wound, a minor wound. Or recall the last time you had a cut. When you had the wound, so it's red, right? So you can see the red tissue, right? Because exposed, because you cut your skin, and then you notice over the next several days it gets redder and then more tender, but then 3, 4, 5 days later it starts to dry up, correct? And then you see dry scab growing, and then next thing you know, the scab fell off, correct? So that's what we call contact inhibition. Did you ever see the skin grow beyond the wound? Because new skin grew, correct, over the cut. But did you see the skin grow beyond where the cut was?
No.
No, that's what we call contact inhibition, meaning once the skin cell hits a wall, it's the cue to stop dividing now. So once a cell hits another or rubs, its shoulder against the next cell's shoulder, it's the signal for the body to, oh, okay, we're done. Okay, we're done growing. Stop now. Stop the cell division. Okay. Malignant cells do not have that. They do not have contact inhibition. Even if they hit the wall, they'll continue growing. If they need to invade another living, another organ just to grow, they'll do that. Okay, so that's how malignant cells kill a patient, because they have no contact inhibition. They grow wherever, there's no limit to their growth. Okay, unlike here, these also have no limit. However, these do not go beyond the organ, meaning these typically do not spread, okay, because they still have contact inhibition. Rate of growth, this one is slower compared to malignant. So this one, because they have a factor causing or allowing the malignant cells to do this, is the shape and size of their nucleus. Again, benign cells resemble normal cells, so their nucleus, the nucleus in a cell. What is the nucleus?
The DNA part of the cell?
That's like the brain of the cell, right? So that's what determines cellular function. So the size of the nucleus in benign cells, because they resemble normal cells, it's normal size. However, the ratio between nucleus to cytoplasm ratio in malignant cells is the nucleus is so much bigger compared to the rest of the cytoplasm of the cell. So because of that, it has a larger brain, so it has a larger rate of growth. Very aggressive, very expensive. Metastasis, again, the benign cells, tumor cells do not spread. These use the highways, the blood, lymphatic vessels to go beyond, and there's no limit to where they can go. General effects, because I gave you an example of a benign tumor growing in the abdomen versus in the brain or in the skull. Either way, either tumor, they have local effects because again, they do not spread. So the problems they cause are localized, okay, wherever they are found. So the abdominal tumor will cause discomfort in the abdominal area, and the skull tumor or the brain tumor will cause problems inside the skull. However, in malignant, because they spread, so they have systemic effects. Okay, so they cause problems not just in the tumors where they're growing, but everywhere else that they spread. Tissue destruction, because these guys do not infiltrate, so they typically do not cause damage. However, again, look at the next statement. And remember the example I gave you, if it grows inside the skull. So if it's unless its location interferes with blood flow, such as what would happen if it was growing inside the skull, then it will cause tissue damage. Okay, so that's the only instance that a benign tumor can cause tissue destruction. Okay, depending on their location. Okay, if they're growing in a tight location, then yes, they can potentially destroy tissue. This one again, because they invade, so these tumors here grow their own blood supply, meaning they will release what's called an endothelial growth factor. So that means endothelium is referring to the blood vessels, right? So endothelial growth factor is released by these malignant cells that commands the body to grow new blood vessels and feed the tumor. Okay, so they'll release that enzyme, and then the body will be forced to grow new blood vessels to feed the tumor. So the tumor will get bigger, fatter, and then more aggressive. And I do not need to repeat ability to cause death. Again, this one depends where is the tumor growing. So obviously, if it grows inside the skull, then of course it can cause death. Otherwise, if it's somewhere where there's around non-vital organs, then the patient should be fine. This one, again, depends if we are able to treat it or not. Any questions on the comparison? So can this be a good select all of my question?
Yes.
Yep. So just for Kurt, okay, I'll give it to Kurt. Okay, let's briefly
Oh,
discuss.
wait, I meant no.
Okay, so this part is not really testable. I'm just going to explain how do we develop cancer. Okay, so a few terms here. We as, let me go back to these characteristics here. Imagine when Brianna was conceived, okay? So her mom and dad, one day said, hey, sup? And then, no, his dad said to her mom, sup? And then mom says, sup? And then Brianna was conceived. So Brianna began as a one cell. Brianna was a single cell at that time. And then after conception, after the egg was fertilized, she became 2. And then she became 4. She became 16, right? So imagine the rate of growth there. Can you picture that? The initial conception, so the rapid rate of growth. And then now she became, a full-size fetus, and then eventually born. So go back here on the characteristics of benign and malignant cells. Doesn't that sound like cancer? Yes or no?
Yes.
Definitely. So therefore, do we have cancer characteristics to begin with?
Yes.
Yes, we had that, but it was only during fetal development, embryonic and fetal development. We stopped doing that after 1 year because after birth, we still had rapid growth. Okay, so imagine your first year of life. You double your height and triple your birth weight. That still sounds like cancer, doesn't it?
Yeah.
Yeah, as far as rate of growth. So it should stop at around that age. Okay, so after 1 year, the rate of cellular growth and division should slow down and become normal. Okay, so meaning keep in mind we have cancer characteristics. So when we go to carcinogenesis, it's just a matter of because there are two, let me just call them the gas pedal and the brake pedal. Okay, so we needed the what's the term? Let me find the term. Maybe it's not used. Okay, the term is called oncogenesis. Okay, so oncogenesis means the rapid rate of growth was necessary for fetal development, embryonic and fetal development, and then of course our first year of life. So as long as there's a balance between the gas pedal and the brake pedal, everything is good. All right. So we have the gas, I forgot what to call that gene, and then we have a suppressor gene. So the suppressor gene is like the brake pedal, okay, to slow down the growth. Now, because we have cancer characteristics, it's really only when we are exposed to carcinogens that we develop cancer. How many carcinogens have you heard of? Let's start with California. How many does California consider carcinogens? Because they're the top in the nation.
Literally in everything. A
Everything,
fishing rod,
right?
everything. Yeah.
So if you look at products we see here, there's always that disclaimer on the bottom that says California, okay, warning in the state of California, blah blah blah. This substance is blah blah blah. All right, so they have warnings in California and not in other states. Okay, so they're much stricter there compared to the rest of the nation. So it's really only if because we have the cancer characteristics, we don't necessarily develop cancer unless we are exposed to a carcinogen. And then once there's exposure and then there's mutation now, and then there a cancer cell is born. Does that make sense? Okay, that's just the simplest explanation I can come up with without having to go through the technicalities of these paragraphs here, right? So let's start now with what are the known causes of cancer. So we have identified viruses and bacteria. So we have the Epstein-Barr virus, HPV virus, the hepatitis B and C viruses. So these have been known to cause cancer. So therefore, if I ask you, can we prevent cancers through vaccination? What is your answer?
Yes.
Yes.
Yes, by getting the hepatitis B vaccine, then you prevent, or getting the HPV vaccine, then you prevent certain cancers. So you get the HPV, you don't get these. All right, you get the hepatitis B vaccine, then there's no liver cancer. All right. All right. We don't have a Epstein-Barr virus, unfortunately. So we do have vaccines for HPV and Hep B. None for Hep C, not yet. Okay, physical agents. So take your pick. So ultraviolet rays, radiation, which is also ultraviolet rays. We've got chronic inflammation, tobacco or industrial chemicals, and asbestos. There's been known link to mesothelioma. Other agents here are, by the way, this radiation here is not only industrial radiation, but also diagnostic radiation or even therapeutic radiation, meaning the radiation from X-ray procedures or CAT scans, even radiation treatment. When we treat certain cancers with radiation, either internal or external radiation, that is still radiation. So although we can kill
I
cancer
got a
with
CT
radiation,
scan today.
yeah, it will cause
Yeah.
potentially other cancers down the line. That's part of the document you will sign. So the doctor will explain this, that we'll use radiation to treat your cancer. However, there's a risk that you'll develop other forms of cancer because the radiation exposure, yes, it will kill cancer cells, but it will also expose normal cells to radiation. So there's always that risk. And it's been linked to these cancers here, right? Chemical agents. So these are mostly chemicals from either industrial chemicals or from tobacco. Again, we don't know, we don't have enough data yet on vaping. Probably because even with tobacco didn't have enough data for until decades later. So it'll be probably the same for vaping. If you know, I'm sure something will come out of those things. Okay, this is not testable. However, it's the questions on the exam for this one is, let me put it this way. So, clergy, are you a mommy?
Yes, Professor.
So let's say you were diagnosed with cancer today. Doctor told you, oh, Miss Clergy, the biopsy we got from your breast came back malignant. And then the doctor will start discussing options for treatment, prognosis, alternative therapy, you know, and then refer you for if you want second opinion. He gave you names of doctors. How are you going to react? You just found out today. Are all those other things that the doctor is telling you going to sink in?
Very emotional.
Okay, so what would be
Heartbreaking.
in your thoughts first?
I'm gonna die.
And who is on your mind? Yourself or
My
your
son.
kids?
My son.
Okay, so it's really because you're having anticipatory grief, right? Because we always associate cancer with pain and death, correct? So you're already anticipating that I'm gonna die, and then what's gonna happen to my kids, blah blah blah, right? So your mind really isn't with the doctor's explanation, correct? So because you're on the first stage of grief, which is denial, and then you go into anger, correct? So you won't be under acceptance until who knows, because people go through grief at different rates, right? You go through grieving on your own time. It's unique for each person. So you probably won't get enough information during that day. So you're not retaining any of the information the doctor is telling you. So when you actually are ready, is the doctor going to be waiting around the corner, just waiting for the acceptance stage to happen? Like, will the doctor wait? Like, visit you every
No.
day and then, no, what stage is the patient in? No, right? They'll go about their job. So, who's there 24 hours a day by the time you actually are in the acceptance stage?
The nurse.
The RN. Okay. So therefore, RNs need to know the basics. What types of cancer are benign? What types of cancers are malignant? Okay. As a rule, looking at table 12-2, carcinomas and sarcomas are malignant. So because did you have medical terminology class? Not a course, a class. Did you have that with A&P?
No.
No? Okay. So let's say this one, adenocarcinoma. So there's a prefix and a suffix, correct? So adeno is referring to breast, lung, prostate, these organs here, adeno, and then carcinoma is that type of cancer. So when it ends with carcinoma and sarcoma, you know that these are malignant tumors. Whereas if it's a oma, except myeloma, because there is no benign form of myeloma, but generally speaking, when we say oma, let's say a myoma, if it just ends with an oma but no carcinoma and not sarcoma, that's usually benign. But the ones listed here obviously are malignant tumors. So if a patient, let's say, has the wrong information, so let's say a patient in the acceptance stage says, oh, I'm so glad adenocarcinomas are very treatable. Okay, that it's just a benign tumor. So what will be the nurse's best response? A, are you okay? B, C, let's talk about your cancer diagnosis and your understanding. D, you want to speak with a doctor?
C.
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 Well, it'll be C. Okay, so you clarify what the patient's knowledge is first, and then you do the appropriate referral. You can call the doctor maybe after you gather data. Okay, but you need to verify first, what does she understand really? What made her say that? Okay, so that's how this is tested. Okay, so you just need to know which ones are malignant versus benign. So we only have the malignant ones here. So we've got carcinoma, sarcoma. Definitely those are, all of these here are malignant tumors. As far as leukemia, really depends because there are 4 types of leukemia. We have acute and chronic myelogenous, and then we also have acute or chronic lymphocytic. Whether it's myelogenous or lymphocytic really depends on what stem cell did they arise from. Myelogenous stem cells go on to become red blood cells, white blood cells, and platelets, whereas lymphocytic leukemia, meaning referring to lymphoid stem cells, typically go on to become white blood cells. Okay, all the types of white blood cells. We'll discuss polycythemia vera later in the, I think this is the second to the last module after respiratory conditions under anemias. All right, and then we have genetic or familial, meaning hereditary cancers. Okay, we have breast here, we have colorectal mentioned. Okay, for breast, we have these tumor markers, BRCA1, BRCA2. So these are what we call we have these, but unless we are exposed to if you have this, then unless you're exposed to a carcinogen, this doesn't necessarily that you're gonna develop breast cancer, right? I mean, you just have the genetic mutations, but still, there's no really guarantee that you're gonna develop cancer. So we've got lifestyle here, too much alcohol, poor diet, or obesity, for instance, are also linked to cancer, particularly heavy alcohol intake. Hormones. If you're taking supplemental hormones, whether it's testosterone or progesterone, estrogen, because certain breast cancers feed off of these hormones, you'll see it when we get toward the end of class today. I'll show you the secondary prevention. You'll see what age groups are highly susceptible to cancer, but we'll go back to that to cancer.org toward the end of class at 2 o'clock. Okay, so as I mentioned earlier, our immune system are capable of fighting cancer cells because so they identify if it's again, the challenge here is they're more effective against malignant because these cells look different, but it's a challenge for them to identify benign because benign tumor cells look exactly like normal cells. And here's proof. You've had AIDS class before, and you remember Kaposi sarcoma? This is a type of cancer of the skin that AIDS patients develop only when they have AIDS, meaning their absolute neutrophil count is now under 500, meaning they have no protection whatsoever. They have no immune system to speak of, and they develop Kaposi sarcoma. Have you talked about AIDS, MedSearch 1? You should have, right?
Yes.
Okay.
Yeah.
You still remember this type of cancer? You should. All right. Let's go to prevention now. All right, so there are 3 levels of prevention. We've got primary, secondary, and tertiary. All right. Okay. Primary prevention is about reducing risk of the disease, reducing risk of cancer. So, do you have the risk here in primary prevention?
Yes.
Well, this is reducing the risk of the disease. So examples here are, we can do chart 12-2, but let's do a few examples here first. So examples here is, you know, sun radiation, UV rays is cancerous, right? So what can you do to prevent it?
Sunscreen.
Okay, so that's an example of primary prevention. Does that make sense? Let's try this chart for more examples. Okay, so chart 12-2. So here are primary preventions, meaning you're just avoiding the risk. Okay, you don't necessarily have it yet, but you're avoiding it altogether. So let's say if you don't smoke, then don't start smoking. If you smoke, then stop smoking, all right? So here, avoid being overweight, avoid becoming obese, and stay active. Limit high calorie, high fat. Okay, eat more veggies, things your mom would expect to tell you. Here, active lifestyle. Stay active. Eat foods, healthy foods, fresh and vegetables, fiber, alcohol. Limit alcohol. Doesn't say stop drinking, but limit or drink moderately. And then what else would be included here? Can we include immunization under primary?
Yes.
Yes, immunizations fall under here. So sunscreen, eating healthy, avoiding known carcinogens. Of course, we can't avoid what we don't know. So I will say avoid known carcinogens, right? So those fall under primary prevention. Let's go to secondary. Secondary prevention is now screening and early detection. They have examples here, but this is, I don't know when this textbook was published, probably 2020, right? Or before. So let's go to cancer.org. All right, so let's say, let's go from the start so that you know how to get here. So cancer.org. Once you get to the home page, scroll down and go under sorry, because they keep changing the website. It doesn't look the same for a long time. They keep updating. Start here. I think it's under screening. Okay, so let's go here, get screen. You remember how I got here? So cancer.org, then just scroll down to get screen. Okay. And go to cancer screening guidelines, this first tab here. And then I guess this is how they do it now. All right. So we've got, they did it by age. Okay, so let's do it by age. So this is cancer.org. These are the early screening and detection. So I'll go back to the textbook. So it clearly says here under secondary prevention involves screening and early detection. So in primary, we were still avoiding the risk altogether, correct? Reducing or avoiding the risk reduction. What is it here now? What is involved in secondary prevention? Does the patient now have the risk for cancer?
Yes.
What is that risk? Based on what you see here, what did the patient develop?
Best.
Or what happened to the patient? Patient got old, correct?
Yes.
Yeah. So the patient reached age 25 to 39. The patient reached 40 to 49. Patient reached 50 plus. So what happened to the patient? What is that risk factor therefore? What is the single most common risk factor for cancer based on age? Okay, so age is the single most important risk factor for cancer. So when you're age 25 to 39, they recommend screening for cervical cancer. Of course, this will only be for male and female or female?
Both. How often should you get screened?
Do you have a cervix, Kurt?
No.
Okay, so this is only for females. Okay, now, because I've seen this website over the years, I started teaching in 2008. This website has changed drastically, okay, from year to year. So in 2008, the recommendation was, it wasn't even based on age. They just said for cervical cancer screening, it used to say any sexually active woman should be screened for cervical cancer. That means if an 11 or 10-year-old is sexually active, we do pap smears on that 10 or 11-year-old. Okay? And before I go any further, these recommendations here are only for the average person right here. These recommendations are for people at average risk for cancer. So if you're not average risk, meaning you have a parent or a grandparent or a sibling that has cancer, are you at average risk?
Oh, yeah.
Are you at average risk if you have a parent, a
You're
grandparent,
high risk.
sibling? Meaning
Yes.
you average.
Oh, yeah.
Yeah. Yeah. Higher risk.
No, are you at average risk? Or do you have a higher than average risk?
Higher than average.
Higher than average, because not every person have cancer in the family, correct? So let's say me, I have no history of cancer for any of my siblings. My parents died from stroke, heart attacks, hypertension. We did not have any history. We have diabetes, but there's no known history of cancer in the family. So I am average risk. So this will apply to me, correct? Or anybody else who have the same shoes as I am. So if a person has history of cancer, a parent, a grandparent, a sibling, cousin, something like that, are they at average risk?
No.
No. So this will not apply to those people. So they can therefore have cancer screening before they reach these ages. Are we clear?
How often should you get scanned for cancer?
Again, these are the recommendations. Depends. If you are at average risk, you follow these recommendations and your insurance company will pay for it because this is from American Cancer Society. These are their recommendations. So insurance companies are obligated legally to pay for these screenings. Is that clear?
Yes, thank you.
Okay, all right. So let's start here. So again, these are only for average risk. So let's say a 21-year-old has spotting, bleeding in between her periods. Is she at average risk?
Yes.
That's still average? Like you have these bleeding episodes in between your monthly periods?
Is it a constant or just a one-time thing?
First of all, oh yeah, it's not a one-time thing. You have it regularly. Is that female at average risk?
No.
Is
She's at high risk.
is she manifesting symptoms of possible cancer?
Maybe.
Yes. So therefore, it doesn't apply here. She doesn't have to wait until she's 25. I'm just trying to impress upon you, when we follow these guidelines. Is that understood? So these only apply for persons with average risk for cancer. If you have symptoms, definitely you're not average risk anymore because you have symptoms of cancer. So you have average risk, no symptoms currently. This is the recommendation. We don't do, for the purpose of screening for cervical cancer, we don't do pap smears until you are 25 years old, right? Again, these recommendations evolve. So how did American Cancer Society arrive at these recommendations? Is it just a roll of the dice? Is it a voting, which is popular? How did they come up with this?
Statistics.
The statistics. So the statistics we saw earlier, I showed you earlier, was the basis. So they saw that based on, every year after year that they compiled data, they seen, we're not seeing cervical cancer cases under 25 anymore. Okay, so now they changed the recommendation. Okay, so they base it on data. These are all based on evidence. Okay. So again, for average risk for cancer, for the purpose of screening for cervical cancer, the recommendation is we start at age 25. Any question on cervical? All right, let's go to breast now. 40 to 49. Now the patient reached 40 to 49. Now what? Breast cancer screening is recommended at age 45 with the option to begin at age 40. Again, recommended beginning 45. But if a patient is 40, they have the option now. So the patient can get it or not, but if they decide to get it, the insurance company is obligated to pay for it. What else is recommended between 40 to 49? Cervical cancer. it's still recommended. So therefore, 25 to 39 and then 40 to 49, we continue with cervical cancer. Again, these are all based on recommendations. And obviously, this will be for both. The first two are for females only. Although, of course, if a male has a lump or a mass felt on the breast, then that means they're not at average risk anymore, so they can have breast cancer screening as well. So males can also have mammograms. For colorectal cancer, begins at age 45. So it's getting younger and younger now. So in 2008, the age was 55, I believe. And then just in 2016, I remember it was 50. Now it's 45. So that means how many cases are they seeing now? More and more cases of colorectal
Many more.
cancer at age 45. Okay, no longer 50. All right. And then here, African Americans, prostate cancer screening at 45. Okay, let's go to 50 plus now. So 50 plus, look at the breast cancer recommendation. We continue. Same thing with cervical cancer screening. We continue at 50 plus. Colorectal cancer still, yeah. And then for lung cancer screening, look at it. There's no recommendation here. None here, none here. And then you see it at 50 plus. The only thing involved here, unlike breast cancer, we have a mammo, cervical cancer, we have pap smear, colorectal cancer, we have a stool-based exam now. It's more convenient because one thing they've discovered was people were not subjecting for colorectal cancer screening because it involved a colonoscopy. I mean, nobody wants a colonoscopy, right? So now it's a stool-based exam. All they need is a stool sample. They can do the colorectal cancer screening based on a person's stool. So they can see cancer DNA in the stool. So it's much more convenient now. So they're having better success at colorectal cancer screening. Here, the only one for lung cancer is a CAT scan. There's really no other thing they do for cancer screening, lung cancer screening. It's only a CAT scan. And same here, 50 plus, we continue with prostate.
Professor, question.
Yeah.
This Friday you testing in cancer only or whatever you cover today?
Yeah, because I have no more topics. It's already 1:30 and I don't want to start with the cancer management because the next topic here is already cancer management on the next page. Oh no, sorry.
Professor,
I still
by any
have to
chance,
finish this. Sorry, my mistake. Yeah, go ahead.
by any chance, will you be able to upload this lecture today?
Sure.
Thank you.
Okay, let me finish first. Okay, diagnosis of cancer. Let's talk about testing. Let's go straight to table 12-4. But since this is here first, let's do staging first. All right. Disregard 12-3 because we want the updated one. So we use cancer.org, okay? The current one, because again, I don't know when this was published, this textbook, and the information might be outdated already. Okay, maybe they've changed it since the publication date of this textbook. So don't study this table, go to the American Cancer Society website for screening guidelines or screening recommendations. All right, let me explain this table. So these are select diagnostic tests to detect for cancer. Now there's a disclaimer here. Because these tumor markers here are not exclusive in cancer, what that means is their presence, these tumor marker presence, is not exclusively found in cancer. They are not really used to diagnose cancers. Okay, because look at this. Look at the last statement. These biochemical mediators may also be found in normal body tissues. Okay, so therefore, is this enough to make a diagnosis of cancer? Because they're found also in normal body tissues. And one more thing is they're also found in non-cancerous conditions, meaning let's say CA129 or CA125. Those are common tumor markers to detect for lung, ovarian, breast cancer. Okay, these cancers here can be detected with drawing blood sample for CA129 and CA125. The problem with those is they're not, again, exclusive to cancer, meaning other non-cancerous conditions also have an elevated CA129 or CA125. So what we'll do is we'll still do the tumor marker test because this is non-invasive. All you need is a blood sample or a fluid sample. And then once they turn positive, then the doctor will recommend a scan. Does that make sense? Because the doctor can't just order an expensive CAT scan, okay, without a basis. So what the doctor will do is the patient has symptoms, right? So they come in with cancer symptoms, and then doctor will order tumor marker first because this is more cheaper than a CAT scan. So once the result comes back high or positive, then the doctor can now justify ordering a CAT scan to screen for these cancers. Is any question about that? Yes or no?
No.
Okay, so meaning, so last conclusion is these can aid in the diagnosis of cancer, but they cannot be used as a sole diagnostic test for cancer. Let me put it that way. Okay, they can aid in the identification of cancer. They can help, but they do not. Them alone is not enough. Same thing for genetic tumors. And we have these scans now, so we're getting more expensive. So we got mammograms, MRIs, CAT scans, fluoroscopy, which is like X-ray. We have ultrasounds, endoscopy to directly visualize the upper and lower GI tracts. We have nuclear imaging. So this is under nuclear medicine. They use radioisotopes, radioactive dyes in order to do, instead of just a normal contrast. So if we're using radioactive contrast, then you go to nuclear imaging or nuclear medicine. PET scan is an advanced scan which can scan your whole body pretty much. They do this to check for metastasis. Because let's say the patient has a tumor in the spine, there's very rare primary tumors in the spine. So most of that is usually metastatic, meaning you have another tumor somewhere. It's not likely to be the only one found in the spine. So they'll do a PET scan to look for the primary tumor. Okay. Same thing with the PET fusion and vascular imaging. Okay. All right, let's go to TNM classification. So this is for staging and grading. So how is this tested? I'll give you the patient's TNM, and then you pick the closest description, okay, for staging. All right, so let's discuss how is this used. So this is a universal classification system for staging system for cancer. So no matter which country you go, TNM classification is the same. So they use the same classification system to stage the cancer. T is for the primary tumor, N is the lymph node, and then M is whether or not there is metastasis. Again, T stands for the tumor, the size of the tumor. N would be the number or extent of lymph nodes involved, meaning has the cancer tumor spread to a lymph node. Reason for this is lymph nodes are the checkpoints for the lymphatic system, meaning if they already found the tumor in the lymph nodes, that's usually indicating that the cancer is malignant, because if it spread to the lymph node, then it has spread to all other body parts where that lymphatic vessels are found. And M is whether or not there is evidence of metastasis. Okay, so let's begin. If it's TX, then that means we don't know. Okay, TX is not good news, it's not bad news either. It's just no news, meaning we did the scan, we did the MRI, we are not sure whether or not there is a tumor. That's what TX means. T0 is good news, meaning we did the scan, we're sure, 100% sure there is no tumor. TIS in situ is it's found usually localized. That's what it means. Okay, that usually means it's a benign tumor because the tumor is not likely to spread. So that's what TIS means. Now this one is kind of subjective. Okay, T1 would represent small, T2 would be moderate, and then T3 would be large, T4 would be like, damn. Okay, so that's really a big tumor. There's really no, it's not based on how many centimeters or how many inches the diameter of the tumor is. Okay, it doesn't work like that because this is very subjective. Because let's go back to the brain tumor versus a colorectal tumor. Okay, a T4 in the brain, a T4 tumor in the brain, will it be the same size as a T4 in the abdomen?
No.
No, so that's what I mean. So this becomes a bit subjective, okay? So T1, all you need to know is that's a small tumor. T2 is moderate. T3 is quite large, and T4 again is damn, okay? So that's a really big ass tumor. Lymph nodes. NX, again, just like TX, not good news, not bad news either. We have no idea whether or not there is, we're not sure, okay, whether or not there are lymph nodes involved. N0, this is good news. There's no lymph node spread. Okay, we know, we checked all the lymph nodes. We don't see any evidence of the tumor there. This one would be indicating how many lymph nodes are involved. So this can go more than N3. Okay, so however many lymph nodes, N4, N5, so it can go up. Okay, but T can only go up to 4. Metastasis also, this one is not limited to M1. This can be M2, M3, or however many. The highest number I've seen is M7. Okay, so it can spread up to 7 organs. So MX, again, no. All X's, we don't know. We're not sure. We can't say yes, we can't say no either. M0, that's good news. No evidence of metastasis. M1, again, it will count the number of body systems involved. So this can go up to M7. Any question on TNM? Okay, let me assess your knowledge. Okay, so let's say the patient's doctor, oncologist, gave a diagnosis of T1, N0, M1. How would you interpret that? Say the patient asked, again, we'll use clergy. Clergy was not listening. She was too worried about her kid when she got her diagnosis. So how would you explain T1, N0, M1 to Miss Clergy?
It looks benign. It doesn't seem to have
T1,
spread.
N0, M1. Say again, Matt.
It looks, wait, say that one more time?
T1,
T1.
N0, M1.
Okay, so it looks like the primary tumor was benign, but it may have spread to somewhere else.
T1, N0, M1.
N0, no lymph nodes, M1.
It can't be benign because there's M1.
Yeah, yeah.
Remember, T is indicating the size or extent.
Mhm.
Okay? Size or extent. So if it's a T1, what is that size or extent?
The smallest.
Okay, so it's a small tumor. And what about what can you say about the N0?
Lymph nodes are not involved.
Right, there's no evidence of lymph nodes involvement. And M1,
It can go somewhere else. It may have gone somewhere
they
else.
can, or it's already in.
Yeah.
Okay, it's already there. Okay, it's already in one other body system. Okay, good job. Okay, let's see. Okay, so we'll stop here. We'll begin management of cancer next week because this is quite long because we have, we'll only discuss 3. We will not include immunotherapy. I will just test on the commonly used treatments for the average person because not everybody can afford immunotherapy, gene therapy, etc. Okay, so we'll just stick with the 3 traditional ones, which are surgery, radiation, and chemotherapy. All right, that's it for today. So your quiz next week will